Um, the goon that I hired to kill the power was an hour off, unfortunately. So I guess I'm on the hook after all for this. Just a quick poll. Who was at the presentation on Wednesday that I gave? Or most of you? Okay. Unfortunately, it's a lot of the same slide deck, so I'll just kind of quickly go through things. The neat thing about this is actually we do have a demo at the end of this presentation that I think will kind of show some of the stuff. So I think you guys will be more interested in what others have to say in the demo capacity versus what I have to say. So I'll quickly go through the slides, and please just raise your hand if you have questions as we're going through here. All right, similar agenda as we had on Wednesday. So quick overview of the Medicaid EHR incentive program, kind of where we're sitting in the state of Michigan and what our plans are going forward. And then we'll really focus in on the quality component of the meaningful use Medicaid program. Included in the quality piece is where we've been, where we currently are, and where we're going with quality reporting for incentive purposes. All right, quick program update. So Medicaid EHR incentive program in the state of Michigan, it's not dead or it's not going away. So we are still moving forward. In fact, we will be starting next week with our formal plans of how we're going to tackle stage 3 of meaningful use with an intended implementation date in early 2017. So we are going to let providers optionally attest in the program in 2017 is our plan at this point. Our system as is right now, we are accepting 2016 attestations under the new modified stage 2 meaningful use. So that actually just opened last week on 6/1, and we've actually had a few providers have come through the door already for 2016 attestations. Like I said, we're carrying forward with stage 3 of meaningful use in the state of Michigan with an early 2017 implementation date on that. And then in regards to the MIPS and MACRA, in relation to the Medicaid EHR incentive program, as it's written right now, folks that are dually eligible, so that are in the Medicaid EHR incentive program and are also MIPS eligible, we see that as being two separate processes at this point. So folks will still have to come into the state of Michigan, submit their quality measures for incentive purposes, but also will go through whatever the MIPS process is at the federal level. So we don't envision that those two are going to be connected in any capacity at this point. All right, just to give a little perspective, so I'll present the numbers here again, like I did the other day. So we got two buckets of providers for incentive purposes. We have eligible professionals and eligible hospitals. So I won't really get into the numbers that much. You guys can kind of follow them yourself. So on the eligible professional side, we have about 5,900 that are actively participating in the program on the professional side, and we have 117 hospitals that are in the program. I think the other thing that I'll point out that's kind of note, the meaningful use payment. So with meaningful use, there's obviously a quality component of that. So on the professional side, there's been over 4,000 providers have attested under meaningful use. So we have CQM data on those providers as well as on the hospital side, the 186 hospitals. And obviously in both those cases, providers have come in multiple years under meaningful use. That's why the numbers are higher, at least on the hospital side. So altogether, $310 million of incentives have flowed into the state of Michigan. All right, focusing on the quality component. So there's 4 different mechanisms right now to get quality data into the state of Michigan. 2 of which are manual in nature and 2 of which are electronic in nature. So the first 2, so we'll focus on number 1 first, is direct data entry. So old-fashioned, you print off a dashboard out of your EHR, you log into our EMIP system, that's our state level system that providers come in and attest to, and they key the information in. Pretty simple. Unfortunately, that's what probably like 98% of providers do, unfortunately, at this point. And we're trying to change that. Number 2 is a PDF upload. It's a glorified version of direct data entry. They pre-populate a PDF and they upload it into our system. Again, manual in nature. So number 3 is QRDA. So I don't think I need to explain that. I think most have kind of hammered that one home. So we're focusing on QRDA, the Category 3 files right now. We can accept a Category 3 file in our EMIP system at this point. So it's basically like attaching a document to an email. You get into our system, you save the XML file, on your desktop or your network drive, and you attach it, just like simple as that. It gets into our system does all the parsing, and things end up in our data warehouse. Number 3, actually this is kind of hot off the press, this one. We actually accept QRDA files now through our information exchange. So there's actually 2 mechanisms, and I got a animation that will kind of show how it utilizes our skimmer project to do that. We can accept it through one of our qualified organizations in the state of Michigan, or we can also accept it via direct secure messaging. So those are the 4 options right now for quality reporting in Michigan. I also want to mention quickly here too, with number 4, it's optional. So we opened it up, but we're not requiring providers to do that at this point. I don't think I need to touch on this. We're all familiar with Category 1, Category 3, I hope. I think we've talked about that high level. So where are we going in the state of Michigan with quality reporting? It's our goal in 2017 to actually shut down any of the manual submission mechanisms, and we really want to move towards an electronic quality reporting. We should be to the point where all EHR vendors can generate these standard QRDA messages and submit them to the state of Michigan. So that's kind of what our plan is at this point, is to make it a requirement in 2017. And like I mentioned on Wednesday, it's the eventual goal to get towards that Category 1 submission QRDA. All right, so let's get into, we're talking about the project that we got going on. We call it our skimmer project. So this is how we accept QRDA files via our health information exchange. And Bo actually showed us this morning as well, but we'll quickly go over it again. So we got our providers, our providers or our hospitals. They got a certified EHR system in their practice, which is capable of generating QRDA messages. They take that QRDA, they can, like I said, they can submit it either via direct secure messaging, or they can submit it via their health information exchange. They submit it into MiHIN. Once in MiHIN, there's a series of validations that take place. First, it validates the schema, validates that it's a valid MPI is contained on the file, and then it just verifies that there's no strange things going on with any of the numerators and denominators, etc. All right, so once it goes through that process, well, the provider will get an acknowledgement sent back that their message has been accepted or not accepted. Once it clears all those battery of checks, then it gets submitted on to its intended destination at the state of Michigan for EHR incentive purposes. So as you can see, our EMIP system is fully linked into our data warehouse, so information will automatically pull into our EMIP system. MiHIN, like I mentioned on Wednesday, has gone through the PQRS certification process. So if that's an intended endpoint as well, that it can get to the federal level for PQRS purposes. Okay, now once we have the data at the state of Michigan, I think there's some really interesting things that we can do with the data. I'll first focus on for providers. So one of the things with quality, with the Meaningful Use Incentive Program, is there are no thresholds set per se. So basically they submit their quality metrics, and are they doing good or are they doing bad? They don't really know. They don't know how they're doing because there's no thresholds per se. So I think one of the things that we can definitely do at the skimmer level is give providers feedback. How do you stack up? From a statewide perspective, from a regional perspective, from a county perspective. We can give them that information once we collect all the data and start aggregating it. So I think there's that possibility, for the provider with that. We can also show comparisons within a practice, and we'll show some of I think EJEF is going to show some of the reporting capability that will kind of demonstrate some of this stuff as well. So at the practice level, comparing providers within a practice is definitely a capability that we could do in the future, as well as comparing clinics and hospitals. How are we doing in comparison to others? And it's not an option right now. So I just talked about providers. So I think there's also a future for consumers of let's make this data available to the consumers. You let them make decisions based on quality data of, for example, I want a cardiologist in Ionia County. What do I do now to do that? I got to do my own independent research. Like, let's make this data available that I could go in and I could filter on a specialty. I want a cardiologist. I want Ionia County. And then here's the specific cardiology measures that tie back. And we can use the data to really put it in the consumer's hands to make decisions on, when you're picking a provider that you want to go to. All right, I also threw up a slide here. These are a few barriers I think that we're going to have to overcome before we can really start getting to that level of really meaningful feedback for both the provider and the consumer. So my first bullet here is EHR vendor participation and cooperation. Obviously, there are still a lot of certified EHR vendors in the marketplace. I know it's starting to weed itself out from stage one. I'm sure someone probably knows the numbers, but there's still thousands of systems that are out there. And each of them may or may not have kind of quirky things about them. So we are seeing some, just with focusing on the QRDA component alone, we are finding some issues with some vendors not being able to submit files for various reasons. So we really are going to have to rally the EHR vendor community around this space to make sure we got standards and that there's cooperation that's there. Especially if we identify an issue. I think sometimes vendors hold on to the fact that, hey, we got this certification and, we don't have to make any changes, for the betterment of, especially if there's identified issues. So that's the first one. Like I've gotten into before, variance in QRDA structure. So we are finding some issues through our skimmer process where we are identifying some issues. One of the issues is the MPI number is not always on the files as they're coming in. If we don't have an MPI number, we can't identify a provider. So that's a major issue within the state of Michigan. The third bullet, MU does not require a standard CQM set based on specialty. Basically, what MU says is you need to submit at least on the provider side, you need to submit 9 measures across 3 domains. They can really be anything. So if I'm a cardiologist, going back to that example, cardiologist A might do measure 1 through 9, let's say. Cardiologist B might do measure 10 through 17 or 18. It's really hard to compare if they don't all submit a standard measure set. I don't know what the answer is to that, but like I said, it doesn't allow for an apples to apples comparison. So it's just one of those inherent things with the program that specialties aren't all submitting the same measures. Next bullet, can a standard measure set be agreed upon for all CQM submission? So I think that's what we're all kind of up against here and that we've all been talking about. So that supports the report ones concept that we all want and desire. Then a final bullet that I identified here is barrier. We need to be able to identify a location. So obviously providers can practice in multiple locations. So when we get a CQM measure that comes in, I don't think it's all that uncommon for a provider to practice in different counties, let's say. So it does make some comparison purposes kind of difficult if we don't know what location that the measure actually came in from. All right. Okay, my final slide here. So I feel like we've really kind of set ourselves up really well for the CQM space in Michigan to be successful. And here's a few of the reasons why. We built it on standards, so I think we're all in agreement. QRDA is a pretty solid standard, and that we're really working to get to that level. Like I mentioned the other day, we got a bunch of smart people, yourselves all included. It was kind of interesting because we actually had a similar workshop. Was it 3 years ago, Rick, when we did this? How many people were in? Maybe 15. We probably had 15 people 3 years ago at this exact time, and now how many people are in the room? 100. I think it's obviously a sellout. So obviously people are people are starting to rally around this, and we got very intelligent people working on this. So, you know, I think we all want it to be successful. Like I just showed with the skimmer project, it's one front door. So all our messages are coming through one connection. We're not maintaining separate connections, separate proprietary things. So that's an advantage of everything coming through one regulated front door, that we can really control things. And that's, you know, that's necessary for this to be successful. Another key bullet is we got a sustainability model built in. So with the skimmer project, it was built on 90-10 funding, focusing initially on the Medicaid EHR incentive program. I think there's, you know, as we're talking here, there's just so much opportunity for other initiatives in the state of Michigan to take advantage of this infrastructure that we've built, which enables us to go forward with a very easy cost-sharing model to be set up. I think it could be very cheap for everyone as we share this across the board. And obviously, we have demonstrated value with all this. I don't think anyone disputes a report once concept. Everyone wants that. And people also like clean data coming into their systems. So when we have the skimmer doing all the data cleansing for us and the schema validations on the front end, that's a win-win that we have a high level of assurance at the end. Once data is pushed on to its endpoints, that the data is in a good spot. So those are the reasons why I think this is going to be successful going forward. So that's all I got for my portion. I guess I'll open things up for questions, and then we'll get the rest of the gang to start rallying for the demo. All right, so I'll open things up at this point. So any questions in regards to the Medicaid EHR incentive program, clinical quality measures, etc.? All right, good. Oh.
Hi, I'm Monica. I manage quality improvement for the Medicaid program here in Michigan. And I just wanted to make the clarification between the Medicaid EHR incentive program and the Medicaid agency and the Medicaid program itself. There are, you know, the CMS requires any state that operates a managed care program to follow a pretty strict set of quality guidelines, and that includes requiring that our health plans monitor their providers, that our health plans are required to set quality standards for their providers. They have to monitor the quality of care that their providers are given or are giving to the beneficiaries, and then the state has to oversee that monitoring. So for the providers in the room, I'm sure you're probably familiar, you get a report from Priority on how well you're doing. You get a report from Meridian and McLaren on how well you're doing. So the plans themselves set standards. We require the plans to set standards, but we don't set the standards on the provider level. We will set a standard for the health plan, and then however the health plan works with its provider network to meet that standard is up to the plan and their providers, and I think you negotiate that through contracts. But I just wanted to make sure that we were clear that we're talking about two separate things: the Medicaid EHR incentive program, which is largely provider-based reporting, and the Medicaid agency that oversees the 11 Medicaid health plans and the robust quality program that's in place there. All right, that was it. Sorry, there was no actual question, Jason.
Good. Thanks for that clarification. Yes.